Good afternoon. It's a pleasure to be here for my twin talk with Anna. It's another point of view of angiodysplasia. So here are my disclosures. And for the next following 30 minutes, I'm going to discuss about how VWF defects can act on the vascular membrane to induce arteriovenous malformations. And arteriovenous malformations, as I said, is a disruption of the normal vascular pattern. You can see here it's a bypass of the vascular bed, and it's very important to realize that this bypass will increase blood flow and prone rupture and hemorrhage. And all the data that are available for until today show that the pathways that are involved are mainly a pathway of vascular stability. So it has been recognized since a long time that angiodysplasia is associated with the von Willebrand factor defects associated with the von Willebrand disease, and we must keep in mind the huge heterogeneity of the VWF defects that are associated with the different subtypes of von Willebrand disease, and it's very difficult to keep all in one phenomenon. And there is also VWF defect associated with the acquired von Willebrand syndrome, mainly shear stress-induced acquired von Willebrand syndrome associated with aortic stenosis, and the worst case, which is the cardiac assist device patients, and VWF defects in gammopathy, monoclonal gammopathy, who is associated with increased clearance of VWF. So here is the picture for the next 25 minutes. So, as Anna said, angiodysplasia are dilated communications between veins and capillaries. The affected vessels are very thin, and there is local expression of angiogenic factors, VOGF and Ang2. They can be found in the whole digestive tract, unique or multiple acquired superficial vascular lesions originating from the GI mucosa or tube mucosa. And the point is that the natural history of angiodysplasia is unknown. In asymptomatic patients, there are older reports that indicate a prevalence in asymptomatic adults less than 1%, with a risk of bleeding in a 3-year follow-up of 0%. But we must mention that these studies were made before the video capsule camera and all the techniques that are available to investigate the digestive tract now. In patients with GI bleeding, the angiodysplasia represent 4 to 6% of the causes of bleeding and are associated with aging, VWF defects, and chronic renal failure. So, as I mentioned, the detection rate has increased because of better diagnostic test performances, high-definition endoscopy, video capsule endoscopy. There is higher prevalence of these lesions in the ascending column in patients in whom there is only age as a risk factor. And more or less 50% of patients have more than one lesion in different locations of the GI tract. That means that in these patients, when you had identified one angiodysplasia, the whole digestive tract must be investigated. So they present in the clinical practice as a chronic and well-compensated anemia or acute life-threatening in rare cases. But what is very characteristic is that this is often recurrent and often obscure GI bleeding only associated with anemia. So the frequency of angiodysplasia was first reported by Dominique Meyer and Edith Fressineau, who performed an interval survey. And what was found in this survey, large survey, involving more than almost 300 centers, was that only VWD associated with the loss of high molecular weight multimer type 2 and type 3 and acquired von Willebrand disease were associated with angiodysplasia. And what was also mentioned in this study was that in von Willebrand disease, the angiodysplasia were diagnosed at a younger age than in acquired von Willebrand syndrome. This frequency was looked in the von Willebrand prophylaxis network, who involved 18 centers in 10 countries, and the authors reported that type 1 is possible, but not type 2N, no type 2N associated with angiodysplasia. And what you can see here is that there is a large range of age, and at the first time of occurrence of GI bleeding, I mean from little children to elderly patients. And in this study, the frequency was similar between type 2A and type 3 von Willebrand disease. And let's go to acquired von Willebrand syndrome. And the first one to report the frequency of the association of angiodysplasia and von Willebrand syndrome was Dr. Aid, who reported the association of GI bleeding in aortic stenosis in 10 patients. And since then, this syndrome was really better identified. Of course, the multimeric structure of VWF confers this activity depending on shear. When the multimers of von Willebrand factor are exposed to high shear, the different domains interact with the platelets and with the MTS13s, and increasing the rate of proteolysis. And that's why von Willebrand factor can be considered as a marker of blood flow or as a Jedinite of the bloodstream. In aortic stenosis, we and others describe the full picture as when the multimer goes to through the stenosed aortic valve, the multimers become elongated and folded and become sensitive to the proteolysis, and there is a decrease in high molecular weight multimer, and there is an inverse correlation between the severity of the disease, here the gradient, and the high molecular weight content. And this is very useful because you can have a quantitative assessment of the loss of high molecular weight multimers in different cardiac settings associated with high shear. And so you can see here that in different cardiac pathologies, such as aortic regurgitation, mitral regurgitation, or at the right side of the slide, cardiac assist devices, you have a loss of high molecular weight multimer, which has been associated with the severity of the disease in aortic stenosis with a gradient, in aortic regurgitation and mitral regurgitation with the volume of regurgitation, and with the pump design with the mechanical cardiac devices. And the full AIDS syndrome is the association of VWF defect with GI bleeding. And in aortic stenosis, there is a referral bias to estimate the frequency of the GI bleeding. It's estimated to be between 7 to 20%. But I must mention that the referral bias could be in increasing the frequency for people who are aware of AIDS syndrome, but most of cardiologists do not know what is von Willebrand factor exactly and how it goes with the aortic stenosis. GI bleeding is the most frequent complication. In mechanical circulatory support, it's even worse because GI bleeding is observed in 20 to 40% of patients, and angiodysplasia have been the most common lesion found at endoscopy, and the worst case is ECMO, extracorporeal membrane oxygenator, which is used for support acute cardiac or respiratory failure. And in ECMO patients, there are mainly GI and epistaxis bleedings, and they are observed in more than 50% of patients. So in those patients, it was pretty elegantly showed by a group of Carlo Bartoli that in humans, in sheep and in calves, when you implant a cardiac assist device and you perform a biopsy of the small bowel, you can identify, here, as you can see here, you can identify an increase in vascularity of the mucosa. You can see here, I don't have any pointer. You can see here these large vessels and here after endothelium staining. And in this study, the authors try to correlate this increase in vascularity of the small bowel with the degradation of VWF. And in the same patients in which they performed biopsies, they performed electrophoresis of VWF, and they shown that there was a loss of high molecular weight multimers together with an increase in low molecular weight multimers and the presence of degradation fragments. So when we speak about AIDS syndrome, there is a recurrent question about is it a bystanding phenomenon, the association between high shear and VWF, or is it a causality between VWF and bleeding in high shear disorders? And to our point of view, a kind of argument in favor of a causality is that VWF predicts hemodynamic success of cardiac procedures. I mean, when you change the stenotic valve in patients, you restore the high molecular weight multimer content. You can see here that there is an increase. And when there is a failure of the procedure, I mean, when you keep low high molecular weight multimers because the valve is not perfectly functioning, you have a recurrence of bleeding. So this is an argument in favor of a link of causality between the two of them. And if it's a general disorder, if angiogenesis is associated with von Willebrand disease because of the endothelial cell dysfunctioning, then there should be other localization of arteriovenous malformations. And in von Willebrand disease, there are very limited reports on the association of angiodysplasia with arteriovenous malformations from different sites, and less than 20 cases, oral, lung-associated, spleen, urogenital, and they are very, very old reports. And so it's really questioning why we do not find other localization of those abnormalities. And the conclusions that can be made is that as we all suspect nasal arteriovenous malformations in case of recurrent epistaxis in von Willebrand disease, they are very hardly reported. Maybe we can consider the diagnostic of hereditary hemorrhagic telangiectasia when there is an association between angiodysplasia and other arteriovenous malformations, because it's unusual. And we must elucidate the role of VWF in the development of arteriovenous malformation outside the GI tract, and it's a very important step. And for that, we need to have studies with a systematic examination of the nasal angiodysplasia in von Willebrand disease. In acquired von Willebrand syndrome, there are few reports, but there are nosebleed reported in aortic stenosis and in patients with continuous flow mechanical circulatory support. And we must say that cardiologists are not aware about angiodysplasia, but they are less aware about von Willebrand factor and nosebleeds. And we must teach to cardiologists that this is a sign of AIDS syndrome. And mucosal bleeding should be recognized as a sign of severity of the disease because there is a link with the VWF defect that is impacted by blood flow. So if we look now at the systematic investigation that is available, there is only one paper who tried to establish if there is other localization of arteriovenous malformation in von Willebrand disease. And you've seen these results during the Anarandis talk. You see that in von Willebrand disease, venular capillary diameter is increased when compared to hemophilia or healthy subject. defects, arteriolar capillary diameter is increased, and there's a torquation index. In acquired von Willebrand syndrome, there has been a very elegant publication of the group of Jorde, who tried to establish the nasal mucosa as a reflect of the digestive tract, and they tried to investigate if the aspect and the vascularity of nasal mucosa should be a predictor of the angiodysplasia of the GI tract. So they performed a systematic nasal endoscopic exploration in 80 patients, supported with LVAD, patients with heart failure, and controls. And so, and they established a score of vascularity in blue. In blue, you've got an hypervascularity, and in green, a normal mucosa. And what they found, after looking at the records for GI bleeding of the patients that were included, is that in LVAD patients, I mean in patients in which there is a lack of high molecular weight multimers, they found 32% of patients with GI bleeding. In those patients, there was 71% of angiodysplasia of the GI tract, which has been identified. And you can see that all these patients had hypervascularity of the nasal mucosa. 0 of them have had normal mucosa. And in the heart failure patients, the GI bleeding was associated with no angiodysplasia. So it's a very interesting study, and I think we must continue to try to establish predictors of angiodysplasia of the GI tract. So looking at the pathophysiology is rather complex. Anna, I've shown you that there are two, she demonstrated two means of regulation of angiogenesis with VWF. One is intracellular regulation, and the second one is extracellular regulation. And with the second one, maybe there is a role for plasma high molecular weight multimers to down-regulate angiogenesis. And to try to draw the whole thing, you have on the left side patients with von Willebrand disease who've got an endothelial cell in which the Weber palate bodies contain an abnormal VWF, and maybe the release and the storage of angiogenetic factors such as OPG, galectin-3, and ANG2 are abnormal. And they have also circulating abnormal VWF, sometimes in type 1 with normal multimers, sometimes in type 2A with decreased multimers associated with increased in proteolytic fragments, increase in degradation, and in type 3, lack of multimers. And you've got acquired von Willebrand syndrome in whom there is a normal endothelial cell with a circulating VWF, which is abnormal, lacking of high molecular weight multimers associated with an increase in degradation fragments. So the four paper from the 3 groups who published on the studies on BOEX really were very important to better understand how that goes on. And to summarize the point, because Anna detailed those papers, there is an inter-individual variability, which is a strong limitation to use BOEX as a model to describe how different subtypes of von Willebrand disease interfere with angiogenesis. And there are some questions, because if the endothelial cell is abnormal in VWD patients, maybe we should observe angiodysplasia in childhood, because especially in severe form of VWD, because the defect is present since after birth. After that, what is the role of aging in VWD and in angiodysplasia? And Are angiodysplasia more frequent in severe defects, type 3 and type 2A, and why? If the endothelial cell is a diseased cell, the storage and the regulation is depending on endothelial cell, how do we explain the success of the replacement therapy and the success of prophylaxis? And are circulating angiogenic factors modified in von Willebrand disease due to dysregulated storage? The first question, in childhood. Angiodysplasia are very rare cause of bleeding, and GI bleeding is a very rare cause, in children. And pediatricians who are not treating von Willebrand disease patients do not search after angiodysplasia when a child is coming with GI bleeding. And you can see on the left part of the slide the report of the French cohort of von Willebrand disease. In 166 patients, you can see that there are very low GI bleeding in the childhood. It's the same results for the Dutch cohort. And of course, you can see that the frequency of bleeding, of GI bleeding, is increasing with age, and it's the same for the Dutch cohort. So GI bleeding and angiodysplasia are really linked to age. And if we look now at the circulating angiogenic factors due to an impaired storage in Weber Pallade bodies, there are no significant differences that have been shown in this paper between the three types of von Willebrand disease. But there is a very, very important substratification on the mechanism of the von Willebrand disease. I mean, the defect in synthesis, the increased clearance, and the secretion. And for that, there is something who is missing. We do not know how to quantify proteolysis. And we should develop tests to investigate this part of the picture. And VEGF, which is not stored in Weber Pallade bodies, is increased in von Willebrand type 3. So there is something to do with the angiogenic factors. And there is a paper that's shown that the high molecular weight multimers are very important for this impaired angiogenesis. In the situation of type 2M and type 2A, there is only one difference is in one case, the case of type 2M patients, the multimers are normal, and in type 2A there is a loss of high molecular weight multimers with an increased degradation. And in 2012, Giancarlo Castaman published this very interesting paper in which he shown that the lack of high molecular weight multimers increased by tenfold the risk of GI bleeding in von Willebrand disease. So there is something to do with the circulating high molecular weight multimers. And that's the situation of acquired von Willebrand syndrome, in which the endothelial component is normal, and in which the only abnormalities are circulating von Willebrand factor. And so what we've learned is that the severity of the biological defect, the severity of the decrease in high molecular weight multimer is depending on the device that you implant. In some device, you have less decrease of high molecular weight multimer because they preserve von Willebrand factor. And so to understand that, we must think about the vascular pulsatility. Pulsatility is the differential between the difference between systolic and diastolic blood pressure, and it's what you feel when you take the pulse. So, in some situations, you've got a decrease in pulsatility in aortic stenosis, for instance, and in heart failure, and in patients with cardiac assist devices. And what has been shown in patients receiving cardiac assist devices is that the range of pulsatility is associated with the risk of bleeding. And the risk of bleeding is increased by fourfold in case of low pulsatility. And there were no data on VWF. So we've built up a model, a SWIN model, to investigate the combination of high shear and different levels of pulsatility. We implant a device in the aorta or in the left ventricle of a SWIN, and depending on the device and the localization, we've got 3 levels of pulsatility. And what we were able to show with different models, a crossover model and a dose effect model, is that when you have pulsatility, when the vasculature answers to the aperture of the aortic valve, you've got less decrease of high molecular weight multimer, even in high shear conditions. That means that pulsatility needs to be investigated to understand why some patients are bleeding or not. And pulsatility may be utilized to reduce the loss of high molecular weight multimers and thereby attenuate the bleeding risk of patients with aortic stenosis, with cardiac assist devices, and why not in von Willebrand disease. Because one of the questions in patients with aortic stenosis or mechanical circulatory support of LVAD is that they all have loss of high molecular weight multimers, but they not all bleed. Only part of them are bleeding. And so the recurrent question is it a bystander effect, the acquired von Willebrand syndrome? And to go with the ANG2 hypothesis, a very important paper was published 2 years ago, a very important paper deciphering the role of ANG2 in angiodysplasia associated with the patients with mechanical circulatory support. In this paper, it was shown that circulating ANG2 is increased in blood of patients receiving LVAD therapy, that the plasma of those patients can induce ANG2 expression and endothelial tube formation through an ANG2 pathway. There is an increase in expression of ANG2 in endothelial cells obtained not from BOX but from biopsy. And there is an activation of angiogenesis linked to the increase in thrombin and activation of factor 11 and factor 12. So ANG2 levels are also associated with bleeding. And in patients with bleeding, ANG2 levels are higher than in patients without bleeding. And it goes with an older paper, a little group of patients, and the authors tried to investigate if ANG2 levels were a good predictor of the finding of angiodysplasia after capsule endoscopy. Of course, the prediction, you can see the area under the curve was 0.7 for the prediction by ANG2 levels, but it sounds that ANG2 is a very important trigger in the angiodysplasia. So to summarize, in acquired von Willebrand syndrome, this is maybe a 2-hit model. The first hit is generating angiodysplasia and more generally arteriovenous malformation. And for that, they need maybe to have a decreased pulse pressure, which is also present in heart failure before implanting the LVAD. There is a mucosal hypoperfusion due to the decreased pulse pressure and a local hypoxia which generates VEGF and favoring angiogenesis. Maybe thrombin has a role to play, and maybe thrombin is the hypothesis for aging, even in von Willebrand disease patients, and maybe acquired von Willebrand syndrome and lack of high molecular weight multimers could play a role in this first hit for generating angiodysplasia. The second hit is more easy to understand. It's the defect in hemostasis, the acquired von Willebrand syndrome, but the platelet dysfunction and anticoagulation as well in those patients. And in von Willebrand disease, maybe it's more simple, or maybe it's not so different, because in older patients you've got a decrease in pulse pressure, a decrease of perfusion of the mucosa, and a local hypoxia. And so we can keep all those features for the first hit. And of course, the second hit is the hemostatic defect by itself. Few words about treatment. Local first, and always try, always local, because you must repeat diagnostic procedures in those patients, because the local treatment is the best. We need to repeat endoscopy, and we need to repeat video capsule endoscopy, and treat locally with plasma argon coagulation. The treatment, prophylactic prevention of recurrence in patients with angiodysplasia, and these GI bleedings are the main trigger for the decision of installing a prophylaxis. Even in GI bleeding, the prophylaxis has a lower efficacy than when compared with other bleeds. The recombinant VWF has been successful in the treatment of 6 patients with GI bleeding. There is an ongoing study for prophylaxis, and a case report have been published using recombinant VWF in a patient with recurrent bleeding from angiodysplasia in a type 2A patient. There are a lot of case reports and little series on treatment to target angiogenesis, octreotide, and somatostatin analogs, thalidomide, and statins. And a very interesting treatment might be the lenalidomide, the Revlimid, who showed promising results in acquired von Willebrand syndrome due to monoclonal gammopathy, in which the Revlimid attenuates the clearance and provides a normalization of propeptide levels and increase the level of VWF. And there are also promising results in VWD with the Revlimid in 5 patients. It has been published, and it leads to a reduction of the number of endoscopies and a bleed-free duration in the mean-free bleed-free duration in the 5 patients of 12 months. So as a conclusion, we must, and you all know that those patients, the management of those patients are very difficult, is very difficult. And it's a very complex situation. And there is really an unmet medical need for identifying and treating and preventing the recurrence in those patients. And the next steps must be clinical and basic science. For the clinical part, a systematic screening for AVM in severe von Willebrand defect or in acquired von Willebrand syndrome must be performed to better understand the natural history of angiodysplasia and AVM. And this implies larger, not national, but international cooperative registries and studies. There is a need for guidance for the exploration, the follow-up, and the treatment of AVM in von Willebrand disease. There is also a need for basic science. First, decipher the impact of low pulsatility on hemostasis and angiogenesis in acquired von Willebrand syndrome, but in von Willebrand disease as well. And there's a need to develop some animal models of angiodysplasia, which does not exist for today. And so I would like to present you some of my collaborators in Lille, Antoine Roch, Emmanuel Jean-Pierre from the research unit, Eric Vambel, Flavien Vincent, André Vincentelli, the cardiac team, Peter Lenting, Katharina Casari, Olivier Christophe and Cécile Denis from the research unit in Kremlin-Bicêtre, and the Centre de Référence of the French network of the von Willebrand disease, Génie, Annie Borel-Derlon, Agnès Véradier, and all the centers. Thank you for your attention.